All right, today we're diving into a really fascinating and honestly pretty bewildering condition called cardiac achalasia. You can think of it as a true medical mystery that all starts with one of the most basic things we do every single day, swallowing.
I mean, just think about that for a second. Something you do, thousands of times a day without even a flicker of a thought? What if that suddenly became a source of stress and real discomfort every single day? Well, for people with cardiac achalasia, that is their reality.
So to really get a handle on this, let's follow the journey of a pretty typical patient. Picture this. A middle-aged woman, she's healthy in every other way, but suddenly something has gone seriously wrong with one of her body's most fundamental functions.
So where does her story even begin? Well, this is Chapter 1, a swallowing mystery. And it doesn't start with a bang. It starts with a slow burn, a series of confusing, frustrating symptoms that at first just don't seem to make any sense at all. Now, what's so baffling here is just how counterintuitive these symptoms are. The medical term for it is dysphagia. That's just difficulty swallowing, and it creeps up on you, slowly coming and going. But here's the real head-scratcher. It's often worse when trying to drink a glass of water than when eating solid food. I mean, how does that work? And to top it all off, feeling stressed can make it even harder to swallow.
All these confusing signals point to a problem that isn't some simple physical blockage. Oh no, it's much more subtle than that. And that brings us to the real culprit, our second chapter, when a nerve fails. The problem lies deep within the body's own internal wiring.
So, the condition has a name, cardiac achalasia, and it's basically a one-two punch of failures. First, that little muscular valve at the bottom of the esophagus, the lower esophageal sphincter, it just forgets how to relax. It stays shut. And second, those muscular waves, peristalsis, that are supposed to push food down, they just stop working. It's a total shutdown.
At its core, this is a nerve problem. Simple as that. There's this nerve network called the Auerbach's plexus that acts as the control center, and it just starts to break down. You can think of it like faulty wiring to an automatic door. The sensor sees you coming, but the signal to open the door just never gets through. And the food, it just gets stuck.
And as you can imagine, as this goes on, the symptoms get a lot more severe. Food and liquid just sit there in the esophagus, which leads to regurgitating at night, really bad breath from the rotting food, and sharp chest pain. And this creates a really serious risk. If any of that material gets down into the lungs, it can cause a dangerous lung infection called aspiration pneumonia.
So, with these confusing symptoms and some pretty serious risks on the table, we get to the next part of our story, the diagnostic hunt. This is where the doctors basically have to become detectives, gathering clues to solve this medical mystery and, just as importantly, rule other things out.
The first big clue usually comes from something called a barium swallow. The patient drinks this chalky liquid that lights up on an X-ray, and it creates this perfect roadmap of the esophagus, showing doctors its exact shape and how it's functioning, or not functioning.
And what does that roadmap show? Oh, it's something really classic. The esophagus, right above that stuck valve, gets all stretched out, dilated, and twisted, while the very bottom part narrows down to this sharp little point. It's such a signature look that it has this incredibly vivid name, a parrot peak appearance.
Okay, so the X-ray gives us the big picture. The next step is to get a direct look inside with a procedure called an esophagoscopy. A tiny camera is passed down the throat, which lets doctors see the valve up close and personal and, this is key, rule out other potential causes. And what they see is this tight, narrow sphincter. Sometimes it's called a golf hole appearance. But honestly, the main reason for this test, and this is absolutely crucial, is to make 100% sure that the blockage isn't being caused by something far more sinister, like a tumor.
But the final, definitive, case-closing piece of evidence? That comes from an esophageal manometry. This is the gold standard. This test actually measures the pressure and the muscle contractions inside the esophagus, proving, without a doubt, that those waves are gone and the valve isn't relaxing like it should. Case closed.
So with all these clues pointing straight to achalasia, we get to the most critical part of the whole investigation, our fourth chapter, ruling out the worst. Because before that final diagnosis is made, doctors have to be absolutely certain they've ruled out a much more dangerous possibility.
And this slide right here shows why that is so critical. Look at the contrast. With achalasia, you're typically looking at a middle-aged woman. It comes on gradually, and she has more trouble with fluids. But carcinoma?
That's more common in older men. It hits hard and fast, it's worse for solids, and it comes with major early weight loss. Getting this distinction right is absolutely everything.
So once that correct diagnosis is confirmed and everyone can breathe a huge sigh of relief, the story shifts. It moves from mystery to resolution. For our patient, this is Chapter 5, a path to relief. And thankfully, there's a very clear, structured way to treat this condition.
Treatment is usually handled in steps. You start with the least invasive options, and you only move up the ladder if you have to. So it kicks off with medication, then moves to an endoscopic procedure, and finally, if needed, considers surgery.
So let's quickly look at what these options are. Medical treatments like nitrates or calcium channel blockers can try to relax that muscle, but as our source material notes, they're often not very effective. Step 2, endoscopic dilation, is more direct. They use a high-pressure balloon to literally force that tight valve open. And if that still doesn't work, the most definitive treatment is a surgical procedure called a Heller's cardiomyotomy, where a surgeon carefully cuts the muscle to permanently release that pressure.
So the story of cardiac achalasia is it's a powerful reminder of how incredibly complex and fragile all these automatic processes our bodies manage every single second are, all without us even thinking about it. And it really makes you wonder, from breathing to your heart beating, what other unconscious process do we all just completely take for granted until the day it stops working?
Welcome back to the Deep Dive. Today we're taking a rapid but rigorous look into the specialized world of functional esophageal disorders. We're focusing specifically on achalasia, sometimes called cardiac achalasia in some of the older sources we looked at.
Right.
Our mission, really, is to get past just the textbook definition. We want to pull out the key nuggets from the clinical sources you shared. Understand that fundamental mechanical failure, pinpoint the really unique clinical signatures that set achalasia apart, and lock onto those incredible visual markers that help make a diagnosis stick.
Yeah, and I think it's crucial we start right there with the mechanism because, well, everything else really flows from it. Achalasia is fundamentally a functional disorder. It's about how the esophagus works or doesn't work, and it's defined by two core failures happening at the same time. The first one, and arguably the most problematic, is the failure of relaxation of the cardia during swallowing.
Okay, the cardia, that's the lower esophageal sphincter, the LES.
Exactly. The LES, it fails to open when the patient tries to swallow, whether it's food or drink. And the second failure is absent primary peristalsis above it. So the esophagus itself isn't generating those necessary wave-like muscle contractions to push things down.
Wow. So it really is a double whammy then. The door is locked shut, basically, and the muscles that should be pushing towards that door are, well, broken. But why is door locked? What's the core neurological reason for this?
The sources are very specific on this. The why is the degeneration of Auerbach's nerve plexus. This is essentially the gut's own nervous system, right? That sort of local intelligence layer within the esophageal wall. When those specific nerve cells degenerate, the signal telling the sphincter muscle to relax, it just gets lost permanently, leading to that closure and loss of function.
Okay, so that nerve damage sets the stage. It's a chronic condition, and it seems to have quite a specific patient profile sometimes. Looking at the sources, the dysphagia, the trouble swallowing, often seems to present in a middle-aged female, well-body build. Is that right?
That's a profile noted in the sources, yeah. Not always, of course, but it's a common observation.
And what I found really interesting is that the sources also mention the dysphagia might actually get worse due to emotional stress. It just highlights that connection, doesn't it? The gut's nervous system and the central nervous system talking to each other. It's not just plumbing, it's neurology mixed with life factors.
Absolutely, that psychological aspect can be relevant. But clinically, the symptom that really stands out, the big red flag for a doctor, is the nature of the swallowing difficulty itself. It's not like, say, a sudden blockage. The dysphagia here is typically of gradual onset, intermittent course, and of long duration. We're talking about something that creeps up, often over years.
Right, a long, slow burn.
Yeah.
And here's a really counterintuitive detail when you really have to clock.
Yeah.
The difficulty swallowing is more towards fluids than solids.
Exactly.
That seems completely backwards compared to, say, a tumor blocking things, right? Which usually affects solids first. Why are fluids the bigger issue here?
Well, it comes straight back to that core pathology we talked about. Solids, especially if they're chewed well, sometimes have enough weight, enough bulk to use gravity or just sheer pressure to eventually kind of force their way through that tight sphincter. But liquids are different. When you swallow liquid, you rely on that sphincter opening up instantly and completely for the column of fluid to just drop through. Because that specific neurological mechanism for relaxation is broken, totally shot due to the plexus degeneration, that liquid just backs right up immediately, and it causes pretty dramatic distress.
That is a fantastic explanation. Wow. It really clarifies why it's a functional failure, not just a physical blockage. But the weird symptoms don't end there, do they? Once that food and liquids start pooling, stagnating in the esophagus, things get pretty unpleasant.
Oh, absolutely. One of the most specific and frankly quite disturbing symptoms is postural regurgitation. Imagine the patient lying down at night and suddenly they're waking up, choking on the stagnant, foul-smelling fluid. It's alkaline, importantly, because it hasn't mixed with stomach acid yet. It's just been sitting there putrefying. This specific type of reflux, happening when lying down, is a very powerful diagnostic clue.
Gosh, I can only imagine how awful that must be. Disruptive doesn't even begin to cover it.
And linked directly to that stasis, you often find severe halitosis, chronic bad breath. It's caused by the stasis of food putrefaction inside that dilated, non-emptying esophagus. And while the main complaint is swallowing, patients often report retrosternal pain too, pain behind the breastbone. But this pain isn't usually from the blockage itself. It's more from the consequences, the esophagitis, the inflammation, the infection caused by that stagnant pool of contents.
Okay, so we've got this chronic, relentless nerve issue leading to stagnation, inflammation, infection. If this goes untreated for a long time, what kind of more general signs show up, late stage?
Yeah, in the late stages, the chronic inability to get enough nutrition down, plus the constant regurgitation, it leads to visible signs of decline. You'll see a poor nutritional state, significant dehydration. Clinicians track this with lab tests, like looking for hemoconcentration, which basically shows the blood getting thicker because of fluid loss. And tragically, you often see repeated bouts of aspiration pneumonia. That's when the stagnant esophageal contents overflow and get inhaled into the lungs.
That aspiration risk sounds terrifying.
Okay.
And I guess connecting this out, the longer-term complications from that chronic stasis can get really serious.
They absolutely can. We're talking structural changes like diverticula, little pouches forming on the esophageal wall. Ulceration can happen, leading to hematemesis, which is vomiting blood. But the most critical complication mentioned in the sources, the one we always have to watch for, is the risk of malignant changes, specifically carcinoma developing in that damaged tissue. And the source highlights something really important here. This malignant change is often a late discovery due to previous dysphagia.
That's the real danger, isn't it? The patient, maybe even the doctor, gets so used to managing this chronic swallowing problem over years that the rapid onset of cancer symptoms gets missed or delayed. Which brings us perfectly to the diagnostic challenge. Rule number 1 has to be distinguishing achalasia from that fatal mimic, carcinoma.
Exactly. And this is where the contrasting profiles become so important. How do they really differ? We said achalasia is often that middle-aged female, long duration, intermittent dysphagia, worse with fluids. Carcinoma of the esophagus, though, it presents a starkly different picture.
How so?
Typically, it affects an old male. The dysphagia is rapidly progressive, developing over weeks or months, not years. And crucially, it's more to solids first because it's a physical mass blocking the way. And you often see it associated immediately with cachexia and a remarkable weight loss. Just taking a detailed history can point you in 2 very different directions. That's why thorough questioning is so vital.
Okay, so the history gives strong clues. But once you're leaning towards achalasia, you need confirmation of that functional failure. The source calls manometry the most diagnostic study. But if the history is so different, and we're about to talk about some pretty dramatic visual evidence, why is getting that pressure data from manometry still so crucial? Why not just jump to imaging?
Because that pressure data is the ultimate proof of the functional failure. Manometry literally measures the muscle, squeeze the strength of the peristaltic wave, and the pressure at the sphincter. It directly confirms the mechanism we started with. It shows that weak or totally absent peristaltic wave in the main body of the esophagus. And, crucially, it shows the clinical hallmark, that clear failure of relaxation of lower esophageal sphincter. You really need that mechanical reading to confirm the why and plan the right kind of mechanical treatment later.
That makes perfect sense. It confirms the how before maybe imaging confirms the where. But okay, let's get to that ha-ha moment for the listener. The unforgettable visual proof often comes from the barium swallow, right?
Oh, absolutely. It's often the defining visual study. When the patient swallows the barium contrast, it outlines the esophagus. And because of the chronic pressure from years of stasis, the whole esophagus often appears dilated and tortuous. Clinicians have this great term for it, a sigmoid esophagus. Just picture the force needed over many years for that tube to get stretched out and twisted, almost like the letter S. It really hammers home the chronicity.
Sigmoid esophagus. Got it.
But the truly classic image, the diagnostic signature you just don't forget, is right at the bottom end. Because that sphincter is clamped shut, permanently tight, the barium just can't get through easily, so the lower end looks pointed and narrow. This sharp tapering creates the highly memorable parrot peak appearance. If you see that shape on a barium swallow image, achalasia is almost certainly the diagnosis.
Parrot peak appearance. I like it. It's such a clear visual that's definitely sticking with me. Now, sometimes even before the barium study, standard imaging can offer clues, can't it? Even a simple plain chest x-ray.
Absolutely. A chest x-ray might show some general effects. You might see a wide mediastinum, which reflects that dilated esophagus pushing things aside. And you often see signs of past or current chest infection because of that aspiration risk we mentioned.
Right. But there's this one provocative question the sources note about the plain x-ray. The absence of gastric air bubble. The source literally asks, why? What's the simple mechanical reason for that?
It's pure physics, really. Normally, every time you swallow even just saliva, a little bit of air goes down with it, passes through the LES into the stomach, and creates that small air bubble you can see on an x-ray. But if the lower esophageal sphincter is clamped shut, fails to relax at all, then no air can get through into the stomach to form that bubble. Its absence is this beautiful, simple confirmation that the gateway is closed.
That's fantastic. So we have the parrot peak on the swallow, the sigmoid esophagus showing the chronic dilation, and the absence of the air bubble on the x-ray. That's quite a powerful diagnostic trio.
Definitely. And then finally, to really complete the picture and, again, rule out malignancy, we use esophagoscopy, upper GI endoscopy. While it helps confirm things visually, its main purpose here is absolutely to exclude carcinoma. You have to get biopsies and cytology samples, especially in doubtful cases. Even if you're 99% sure it's achalasia based on everything else, you must look for any malignant changes because of that known long-term risk.
Okay, absolutely critical safety check. And what does the esophagus actually look like through the scope in a typical achalasia case?
Well, visually, the scope confirms that seat of stagnation. The sources describe the esophagus as wide, filled with dirty water, often showing signs of inflammation, esophagitis. Then, when the scope gets down to the very bottom, to the cardia, it looks eccentric and narrow. This gives us our second classic visual sign, the golf hole appearance. The tight, narrowed opening looks like a golf hole, and critically, the scope usually can't pass through easily, physically proving that civic tight restriction.
Parrot peak and golf hole. Got it. So, once the diagnosis is nailed down and we understand the neurology, we have the pressure data, we've seen the parrot peak in the golf hole, how do we actually treat a muscle problem that's ultimately caused by nerve damage? Let's quickly go through the management.
Right. The treatment approach is generally stepwise. You often start with medical options, which are mostly just palliative, aiming for symptom relief. Then you move towards mechanical disruption. And finally, if needed, surgical correction.
Okay, let's start with medical. Since it's a muscle that won't relax, I'm guessing the drugs try to force it open somehow.
That's the basic idea, yes. The initial pharmacological options usually involve drugs designed to relax smooth muscle. Things like isosorbide dinitrate, that's a type of nitrate, or calcium channel blockers. They aim to reduce the muscle tone in the sphincter. However, and this is a really critical detail from the sources, they are usually ineffective.
Huh. Why only usually ineffective if they're muscle relaxants? Is it because the root problem isn't the muscle itself, but the nerves controlling it?
Exactly that. The fundamental pathology is the death of those nerve cells in Auerbach's plexus. It's not just a muscle that's temporarily spasming or overly tight. The actual signaling mechanism to relax it is gone. So these drugs might slightly reduce the overall tone, maybe offer some minor temporary relief for some people, but they very rarely fix the underlying mechanical blockage. They mostly just buy some time while you plan a more definitive intervention.
Right. Which brings us to endoscopic management. This sounds like the most common approach for getting real sustained relief.
Right.
This is where things get more mechanical and direct.
Correct. If medical therapy doesn't cut it, the next step is often forcible dilatation. The goal here is to physically disrupt, actually rupture, some of those persistently contracted muscle fibers of the sphincter. This is done using a special high pneumatic pressure balloon. It's positioned right at the tight spot and then inflated very forcefully. This physically stretches and tears the muscle fibers, creating a wider opening. It does carry some risks, like perforation, but it's often very effective at restoring the patient's ability to swallow, at least for a significant period.
Okay, forceful dilatation. And if that still doesn't provide good long-term relief or maybe isn't suitable for some reason, what's the gold standard surgical fix?
Then we move to the most definitive option, which is surgery. The gold standard procedure is called Heller's cardiomyotomy. In this operation, the surgeon carefully cuts through the tight outer muscle layers of the lower esophageal sphincter, but leaves the inner lining, the mucosa, intact. This releases the constriction, opening up the passageway. The sources note it can be done either through the abdomen or the chest, traditionally as open surgery, but nowadays it's overwhelmingly performed laparoscopically, which is much less invasive and has a quicker recovery.
Okay, Heller's cardiomyotomy. Great. Let's try and synthesize this whole picture then for you listening. Achalasia is, at its heart, a distinct chronic failure of the nerves, specifically Auerbach's plexus, leading to that tight lower esophageal sphincter and the absence of peristalsis, the muscle waves. The key clinical clue, the thing that should make you think achalasia, is that unusual pattern of dysphagia, primarily affecting fluid swallowing, often gradual, intermittent, and long-term.
Exactly. And its diagnosis hinges on confirming that functional failure with manometry, which is then backed up by those really unforgettable visual signs on imaging. You've got the severely dilated and twisted sigmoid esophagus, that classic restrictive parrot peak appearance on the barium swallow, and the narrow, tight golf hole appearance you see during endoscopy. The imaging really paints a picture of chronic obstruction.
And the relevance here, the big takeaway, beyond just understanding the disease, has to be that differential diagnosis, right? Even though achalasia itself is often slow-moving, you have to treat every case initially as a high-stakes investigation because the symptoms, especially early on, can overlap with esophageal carcinoma. You absolutely must investigate thoroughly to make sure those long-term swallowing problems aren't masking something far more sinister.
Precisely. Which leads us perfectly to a final, maybe slightly provocative thought for you to consider, based directly on those complications we discussed. Given that the dysphagia and achalasia is typically of long duration, often stretching over years before a definitive diagnosis is made, think about the real danger of chronic symptoms leading to habituation. Habituation for both the patient, who just gets used to it, and maybe even for the doctor managing it long term. How often might the sense of, oh, it's just the achalasia acting up, actually delay the necessary aggressive investigation, the repeat endoscopy, the biopsies, the cytology, and could that delay lead to a tragically late discovery of associated fatal complications, particularly malignant changes? It's a powerful reminder, I think, that even chronic disease demands constant vigilance.
It's a really critical takeaway, an excellent and slightly sobering note to end on. That was the deep dives into cardiac achalasia. Thanks for joining us.